Hello and welcome to another edition of Heart Failure Minutes. I'm Dr. Milica Vukićević, a Harvey scholar coming from the MGB campus in Boston. Today we turn to a national case study that challenges the global HF community. Across the world, despite remarkable discovery of life-saving therapies from GDMT to mechanical circulatory support and transplantation, implementation continues to lag. Too many patients never receive timely diagnosis, early stages are routinely missed, and advanced therapies remain concentrated in only a few centers. Yet one country, Kazakhstan, has built a nationally integrated model to identify, track, and treat heart failure across the entire population. Their work represents a unique instance where political will, national financing, education, and digital integration converge into a functioning HF ecosystem. To explore how this happened and what the rest of the world may learn, I'm joined today by Professor Mandeep Mehra. Why and how did Kazakhstan come together to build a national HF system? What drove a country to organize itself in such a cohesive way, politically, medically, and structurally? And can you address heart failure at the national scale?
Well, Kazakhstan faced a critical crisis. The country carried one of the highest cardiovascular mortality rates in the WHO European region, with heart failure attributable deaths that were nearly tripling in a short span of 5 years. It was a national economic and clinical emergency. What is remarkable is that the response was not piecemeal by the country. It was an intentional, coordinated, and state-led comprehensive response. The government first recognized heart failure as a priority in terms of its tackling and created a national heart failure roadmap. This roadmap was backed by ministerial financing. They centralized all advanced cardiac therapies under the rubric of a national scientific cardiac surgery center. Then this was built outward into a network system of community heart failure clinics, regional heart failure offices, and national coordinators with expertise in heart failure. They invested in diagnostics, ECG, echo, NT-proBNP, made them free and fully accessible across the country. They established the Kazakhstan Heart Failure Society and launched the European Heart Failure School, embedding a sustainable educational pipeline. Importantly, they created a national digital registry that unified all of the heart failure data and allowed real-time tracking, communication, and telemonitoring. This didn't obviously happen by accident. It was a very deliberate decision at the ministerial, governmental level to ensure that every citizen, regardless of geography, could be identified early, treated appropriately, and referred equitably. That political will is the true catalyst for this system.
What were the outcomes of this model? From your evaluation of the national program, what have been the measurable and structural outcomes of Kazakhstan's HF model?
Yeah, the outcomes are quite striking, both in numbers and in system behavior. So first of all, there was a massive expansion in diagnosis. Heart failure detection grew from just about 12,000 cases a year to 35,000 new cases diagnosed just in this year alone, and this year isn't even done yet. This was largely due to widespread NT-proBNP testing and echocardiography across these coordinated centers. Second was a nationwide network of heart failure clinics. The number of these heart failure clinics and offices increased from just 75 in 2021 to 230 in 2023 to nearly 300 by today. And this is almost a tripling or quadrupling in just 2 years. These clinics are now the backbone of population health screening in heart failure. The third thing was a dramatic growth in advanced heart failure therapy, which was provided to all with equitable access. 657 LVADs done, 106 heart transplants, which have been performed just since the program's inception across only 4 surgical regionally set surgical hubs, ensuring equity across the country. The fourth thing was a workforce development. Over 220 cardiologists and 50 nurses have been trained in a standardized heart failure curriculum supported by regional heart failure coordinators and the annual heart failure school. The fifth was a digital transformation and accountability, and a very important aspect. Through this registry, clinicians now track GDMT titration, readmissions, and registry completeness. It has shifted the culture from episodic rescue-based care to continuous data-driven management. Finally, the national level achievements in cardiovascular disease outcomes are not to be laughed at, because Kazakhstan is the only country in Central Asia to already meet the WHO target of a 25% reduction in premature cardiovascular disease mortality by 2025. And heart failure care integration is cited as a key contributor to this value. This is population health management brought to life in a real manner.
Very impressive data. What can the world learn from the Kazakhstan model? For other regions struggling with implementation gaps, what lessons does this model offer?
Well, in my viewpoint, there are at least three key lessons for the global heart failure community. The first is that implementation is a political choice, not necessarily just a clinical one, right? When diagnostics, registries, and therapies are state-funded and mandatory across the entire system, adoption becomes universal, not optional. You simply cannot reach population coverage without that backbone. The second lesson to be learned is that building the base is essential before you build the apex. Kazakhstan didn't just start with transplantation. It actually scaled to it later. It started with identification, standardized education, and community clinics in heart failure. Advanced therapies only achieved where they are now once the front line was strengthened. So that is a key lesson. And the third lesson is that real-time data is the beating heart of all modern heart failure systems. The registry platform transformed the country from static reporting to live surveillance, enabling monthly feedback loops, improved GDMT adherence. More than 80% of patients are on guideline-directed medical therapy who go through these clinics, and uniform national quality standards. Ultimately, this model teaches us that heart failure care becomes equitable only when a nation decides that every citizen deserves a chance at early identification and advanced therapy. Kazakhstan's model shows us what happens when willpower, financing, and a uniform system align together.
Thank you very much, Professor Mehra, for illuminating how a country with vast geography and significant cardiovascular burden chose to redesign its heart failure system from the ground up. The Kazakhstan model reminds us that innovation is not only about new molecules or new devices, it is about building systems capable of delivering them. When governments, clinicians, data systems, and communities move in concert, even the most daunting cardiovascular challenges can be transformed. I'm Dr. Milica Vukićević, signing off for now. Until next time.